We'll be talking about another series or another video part of the series. Today we'll be talking about troponins. So troponins are proteins that are present in the cardiac muscle and they regulate muscle contraction. There are two types of troponin, troponin I and troponin T, and they both serve as markers for myocardial injury detection. Elevated troponin levels correlate with the severity of the damage to the heart muscle, and also a prognostic tool for the risk of heart attack and cardiac death in the future. Now, new labs or a new generation of troponin is high sensitivity troponin, which detects very little amounts of troponin in the blood with greater accuracy. However, there needs to be a careful interpretation because it could cause a false positive and it's not very specific, as many different causes can elevate troponin other than acute myocardial infarction, and we'll be talking about those. Now, troponin in renal disease. In cases of a patient having renal failure, what happens is the cardiac troponin T actually becomes elevated, and the reason for this is that patients with renal disease on dialysis, these patients will have some sort of strain on the heart, fluid excess in their body, there will be microvascular damage to the heart, and that causes a release of cardiac troponin. Now, what happens is that cardiac troponin T is not filtered out by the dialysis machine, and therefore that's why it increases. And also because it has a longer half-life than cardiac troponin I, it remains more in the bloodstream, and therefore it's very natural for patients on dialysis with renal disease to have elevated levels of cardiac troponin T. However, it's less likely for cardiac troponin I to be elevated. Now, in this case, what you would do is, in these patients, you must have baseline investigations. And these baseline investigations will help us, even though on baseline they have high levels of cardiac troponin, but on a serial management, you will see that after the baseline there is an elevation, and that could indicate that there is an ongoing acute myocardial infarction. And that's why clinicians have to be careful in interpreting these results. And again, away from renal disease in general, acute myocardial infarction diagnosis relies on a troponin above the 99th percentile, and there has to be this rise and fall pattern that we'll be showing in a moment. As we said, we'll be discussing the non-ischemic causes of elevation in troponin. This table actually shows all the causes. Now, the non-ischemic causes can be, for example, heart failure itself, myocarditis, pericarditis, arrhythmias like tachycardias, and even bradyarrhythmias. LVH can all reflect myocardial injury. As we said, renal failure itself also causes elevations in troponin, sepsis, pulmonary embolism, because pulmonary embolism causes strain on the right side of the heart, stroke, extreme exertion, and amyloidosis, which is actually accumulation of proteins or abnormal proteins in the cardiac muscle, which cause then damage. So these are all elevations not related to coronary blockage. Now, the use of troponin it's very useful in actually for diagnosing non-conclusive NSTEMI, non-ST elevation myocardial infarction, because to confirm a non-STEMI you would need a cardiac biomarker like troponin. However, it doesn't aid in the diagnosis of a STEMI, because STEMI is an ST elevation myocardial infarction. It's enough to actually follow the criteria, which is more than 1 millimeter ST elevation in 2 contiguous leads, and therefore a troponin is not needed. But the thing is, troponin is useful for risk stratification and prognosis for both NSTEMI and STEMI, but not for the diagnosis of STEMI. Okay. And then, as we said, the prognostic significance that we just spoke about it can tell us that the risk of a patient for developing acute cardiac complications and short-term prognosis. Now this is the rise and fall pattern that we talked about. You can see that there is a rise. This is the 99th percentile, or the upper limit of normal. And this is a rise in troponin. And you can see that the rise is actually happening throughout many days. Like the rise and fall pattern could take about 6 or 7 days. So relying on the rise and fall pattern can actually take a long time, and therefore you cannot provide prophylactic management for a patient if you were to only rely on troponin. So that's why there are different ways of using troponin with the clinical picture, with the ECG, using several scores like the heart score and the TIMI score that we will also be talking about later on, to help us decide if this patient does need treatment right now at this moment, or we can perhaps discharge the patient confidently. Now, as we said, high sensitivity to troponin identifies 90 to 100% of patients with acute myocardial infarction, but with limited specificity, so there might be a false positive ongoing. And then, of course, 2 or more values showing delta wave, as we also talked about, can distinguish an acute injury from a chronic. So the delta wave actually tells us that there is an acute ongoing injury in the heart. In a chronic condition like heart failure, there will be not a delta wave. A delta wave is very specific for example, an acute myocardial infarction. Now, this brings the idea of serial troponin and serial labs for troponin, and the European Society of Cardiology recommends the 0-3 hour interval. So taking a blood sample at initial presentation of the patient and then 3 hours later. Some also recommend the 0-1 hour interval, which is of course going to take less time and going to cause less ED congestion, more diagnostic accurate. This was actually a paper that I read, and you can actually go and look at this paper. And the paper actually was saying that you can, there was a specificity and negative predictive value to rule out myocardial infarction was more than 95%. So it's a very useful algorithm, and some hospitals use this 0-1 hour algorithm. Depends on which hospital you work in, depends on the kits that are available. You can actually use the 0-1 algorithm. And to note, a serial troponin plus a low TIMI score can actually exclude an acute myocardial infarction. Now this is the TIMI score, and this is the heart score. So both have a category, age category, risk factor category. Now here you have an aspirin use in the last 7 days, which is not in the heart score, and also a blockage of more than 50%. You can also see that the TIMI score relies on a positive cardiac marker, while the heart score actually goes more specific into how much the troponin was elevated. Now you do not need to memorize these scores. There is this application called MD CALC. I'll put the link in the video where you can actually download it and use it in your clinical practice. Now, a patient with a non-ST elevation myocardial infarction with an elevated cardiac troponin will have a 3.1 or 3-time-fold increased risk of cardiac death. The thing is that any patient with an elevated troponin, even though it's not an acute myocardial infarction, means worse prognosis, worse outcomes, more risk of cardiac complications in the near future. So the worse the elevation, the worse the prognosis. Now, some people talk about BNP. Now, does BNP add any benefit whilst using troponin in the scenario of an acute coronary syndrome. Actually it doesn't, and the reason for that, because BMP increases the sensitivity. We already use high sensitivity troponin. We do not need something that increases the sensitivity, and it actually decreases the specificity, so it's not routine, and it will not add any benefit. Now this is a case, and it's a 68-year-old male with a history of hypertension, type 2 diabetes, and hyperlipidemia, presenting to the emergency department complaining of substernal chest pain. So there are risk factors for acute coronary syndrome, and the pain started 1 hour ago while watching television. The pain nature is crushing pressure and also radiating to the left arm. So this actually goes a lot with acute coronary syndrome. And he reports shortness of breath and sweating, and he takes aspirin once daily. These are his vitals, his heart rate, blood pressure, and respiratory rate. And also on ECG, there is an ST segment depression. So this is a non-STEMI of 1 millimeter and leads V4 and V6. So in this case, it's a non-STEMI. You would need a troponin to confirm the diagnosis, and that's what was done. A troponin was done, and it was found high at 0.18 nanograms. So plugging all this data into the heart score and the TIMI score on MD CALC, now this is what you would find. You would find a high heart score and a high TIMI score, and you can actually read it. It can even give you the management, next steps in management. And next steps would actually be to intervene and prepare for revascularization. You would actually cover with several medications. We'll talk about management in a separate video, but you'll have to give medications and prepare them for a PCI if there is a close PCI center nearby. Now another troponin was done again, and there was a rise in the troponin. Now you would need a third sample to find the fall, because now we've found the rise and we need a fall to actually confirm, but that takes very long time. Using the TIMI score and the heart score actually confirm the diagnosis of a non-STEMI, and we actually start management before having to wait. This is another case. It's a 55-year-old female. She has hypertension, high cholesterol, but it's controlled hypertension, and she presents to the emergency department with atypical chest discomfort. The pain is located on the left side. It is sharp and fleeting, so this doesn't really go with an acute coronary syndrome, and aggravated by certain movements. Again, this typical acute coronary syndrome pain does not change with movement, but again, you cannot exclude. She reports discomfort, and it's been intermittent about 6 hours. Denies shortness of breath, nausea, or sweating. Initial ECG shows no ischemic changes. A troponin was done, and it was undetectable. So again, plugging all of this data into the heart score, it's a very low score, and here you can actually kind of rule out an acute myocardial infarction, because the risk for developing an acute coronary syndrome or cardiac complication is only 1% or 1.7%. So there still is a risk, but depending on the scenario, we can effectively rule it out. Now, for me personally, I might wait for this patient for another hour to do a serial troponin. If the troponin remains again low, then I would discharge this patient safely. And thank you for listening to this video. Hope you found it useful, and please subscribe to the channel and stay updated with the latest videos. Thank you very much.